It's very nice to be here. I'll try to speak slow. My Italian's very poor.
Closer to the mic.
English is a little bit better. So, this is Dr. Chris Gordon, and he and I will share this time. We won't take the full half an hour. We want to ask questions, but we certainly want to make sure that the people come after us get enough time, because they're really the most important. Again, my name is Dr. Gina Nikkel, and I am the CEO and president of the Foundation for Excellence in Mental Health Care. And we are the ones that are funding this first year of planning and getting everything ready to go for HOPEnDialogue, and we'll be involved with the project the whole length of the way. I wanted to introduce my colleague, Kevin Aspergren, if you can raise your hand. He's our new Chief Philanthropy Officer. He's been working with me for, it seems like a long time, but probably only a month. So I'm going to point him out later on to you. So the reason that the Foundation for Excellence in Mental Health Care is interested in this is we are formulated as a community foundation. Does everybody know what a community foundation is? Yes? Nope. People are going, okay. So a community foundation is one, there's private foundations, there's family foundations that give out money. A community foundation is one that is organized sometimes regionally, sometimes a country, sometimes a state, sometimes, little areas. Ours is a global foundation, meaning that all of us as a community want to see better mental health outcomes. So all of us, may not be able to give $1 million to get this job done, but each of us can give $10 or $15 or $20, depending on what your budget can afford. So as a community foundation, people in the United States actually get tax credits by giving to us. And in other countries, we just have relationships. So we get money from people all over the world. We pool it, and then we're able to fund things like this. So that's what we do. We started because several of us around the world read the book Bob Whitaker's Anatomy of an Epidemic in April of 2010. Now, those of us that got together, psychiatrists, psychologists, public policy people, social workers, family members, people with lived experience, started scratching their heads about there needs to be a better way. And in the back of Bob Whitaker's book, he's a medical researcher, and he asked questions that we thought we needed to be asking of ourselves. And in his last chapter, he mentioned a few things that he thought was working around the world, and HOPEnDialogue was one of them. So when we got together to start the foundation, several of us reached out and talked to him, and he put us all together. And a very gracious donor helped us start the foundation. We knew, when I was hired as the CEO, we knew that we had to have some pillars. Some really standards to look at. And so HOPEnDialogue is one of those pillars that we raise dollars for, as well as the Hearing Voices Network. So we are very, very glad to be here. I've got some information on the foundation on my cards. Feel free to take one. That's enough about me. I'll answer questions later. We're just really, really glad to have you here. I don't know many of you in the room, but there's a lot of people that I do know in the room. And what I love is, meeting Jaco and I realized that we had never met each other in person, but through Skype and telephone calls, we felt like we knew each other. And so I love having these relationships. And I want to thank Raffaella and Giuseppe for what you are about ready to embark on. Thank you for bringing this group together. When I first started and knew that I was going to be looking into HOPEnDialogue, I spent a lot of time with Mary Olson and Doug Ziodonis and others, and Dr. Chris Gordon, who is on our board right now, but started out as our first recipient. And I'm going to turn it over to him so he can talk a little bit about the work that he is doing.
Thank you very much, Gina. Can you guys hear me in the back? Yeah. Okay, good. So as Gina said, the company that I was then working for and from which I retired 2 days ago. So this is Chris Gordon 2.0 up here now. We had the great honor to be the first recipients of a grant from the Foundation for Excellence in Mental Health Care. We had learned about open dialogue through Bob Whitaker, but we had learned about Bob Whitaker through a person who received services from us, who came to my office and hocked me to death because I didn't know anything about open dialogue. And that service recipient has now been doing open dialogue for several years and reflects on it as the most meaningful and powerful modality he and his family have ever experienced. So we're deeply indebted to him for this vision. I'd just like to share with you a couple of reflections on what our experience providing open dialogue over the last 9 years has been, as it may be germane to the project of HOPEnDialogue. So one reflection is that we had excellent training. We had 2 years of training with Mary Olson, and it was superb. So I resonate with Jaco's expression of conviction that strong training is a foundation for this work. I would also say, as a cautionary note, that when we began our work with Mary, like many people, we were impatient to begin our network meetings. So we began our network meetings after only about 6 months of our training. And we therefore called our work the collaborative pathway rather than open dialogue because we were afraid of representing ourselves as practicing something we were not completely trained in. I think this is relevant because our results in our work over time have been really quite good and very exciting, but they haven't been Finland quality outcomes. They haven't been those fantastic outcomes that Jaco showed us. And I think a couple of observations explain this phenomenon. The first is what I just said, that we were trainees. And in some ways, it was perhaps an error to publish our results as if it was a reflection of the quality of open dialogue, when really it was a reflection of the work of open dialogue students and then early practitioners. And I think this is very important. Secondly, we've now treated something like 45 young people and their networks. And of all of those 45 people, only a single person came to us completely naive to treatment. The vast majority were refugees from standard care, meaning that the vast majority had already been started on medications. So even those who elected to try to stop or to stop medication or radically reduce it during their period of time of work with us were going through withdrawal. And this is a very, very important distinction. The one person who came to us completely naive to treatment came with a family that was very interested in trying to avoid antipsychotic medications, as was she. And she did weather the storm of her psychotic experience without any antipsychotic medication and has now done well for 2 subsequent years. So I think that the idea that the cohort in the original studies were largely new to the system is an important distinction. The other thing I would reflect on is that although there are exceptions, the vast majority of the people we have served and their networks have really, really loved this approach to work. I realize Russell and Steve's concern about comparing open dialogue to standard care and not wanting to prove that open dialogue is better than bad standard care. But I got to tell you, it's a really low bar because standard care is so bad. And as a result, we had absolutely no trouble recruiting people and their families. They were even willing to put up with our completely obnoxious informed consent process and research instruments, which our IRB required of us, because they were really interested in participating in an open dialogue approach in which their families were welcome, included, in which they were really listened to and treated with dignity and respect. So that is another observation which I would like to share with you. I think that it was relatively easy to bring open dialogue to the company where I was working at the time, because that company has a long tradition of person-centeredness, self-directed care, recovery orientation, and a healthy skepticism about the claims of the biomedical model. Not rejecting it, but healthy skepticism. So when folks in our company encountered open dialogue, it was like they were encountering an old friend. There was a feeling of recognition, familiarity, an oh yes response. And this is, I also have one foot in the academic world in Boston, where I'm on the staff of Massachusetts General Hospital and McLean Hospital. And so I've been invited to speak about open dialogue. And when I speak to rooms full of psychiatrists and other professionals in those settings, I don't get the oh yes. I get the quizzical look, and I can sort of see the thought bubble over people's heads going, huh? So my point is that bringing open dialogue to an organization that is already attuned to these values is vastly easier than undertaking to transform the fundamental values of the system. So I guess the last thing I will say is that our experience at Advocates is that you really can take teams that are already in existence and open dialoguize them. It's quite doable. And I'm tremendously excited about the Hope and Dialogue project, and hope that our experience may in some ways be helpful to its success. Thank you.